Our speaker tonight is Dr. Nitin Chowdhury. Dr. Chowdhury is the co-founder and medical director of the Vitreous Retina Macula Specialists of Toronto, a premier academic retina practice. He is an internationally recognized vitreoretinal surgeon with affiliations at both the University of Toronto and Harvard Medical School, an ophthalmology lead at the Cleveland Clinic, Canada. He is universally recognized as a thought leader in retinal imaging and the diagnosis and treatment of rare disorders of the retina and vitreous. Welcome, Dr. Chowdhury.
Thank you. Thank you for all inviting me to give this talk tonight. Can I just make sure that everybody can hear me okay? Great.
Yes.
So these are my disclosures. We're going to be showing images from a variety of devices today, and one of them is Optos, and obviously the other one is Zeiss. So we'll be showing some images from those unique devices. Well, let's get started with a polling question. I think we have a series of questions. We can bring up maybe polling question number 1. Do we have that question? Great. The question is, the vitreous is primarily made of all of the following except. I'll let you take a look at those answers so we can get a good view. All right, good. See our responses. It's actually hard to see it from where I'm at. And can't see it from my current view, but let's move on. Maybe we can make that a little bit bigger as we go forward.
Dr. Chowdhury, so
our object,
do you want
yes?
me to read out the responses? So for water, it's 13%.
Yeah, that would be great.
B is 8%, collagen 3%, and lipid 76%.
Great. So we'll learn all about what the vitreous is made of very shortly, so we can actually get a better handle on what that answer is. Try to get everything working here again. Excellent. So our objectives today are to understand the anatomy of the human vitreous, become familiar with the formation and the concept of how these opacities begin to form within our vitreous, learn to evaluate the impact of these vitreous opacities in a clinical setting and the patient's quality of life. We want to get a better handle on how to counsel patients about the various options that are available for managing vitreous opacities, and then also a good understanding of the science of YAG laser vitreolysis, which is an emerging technology to deal with this. All right. And on the right here on the screen, you can actually see an OCT of a patient with an ERM and an overlying vitreous traction. And so, it's interesting when we look at these kind of videos, we don't really realize until we look at them that we have a large amount of data that's being collected. And so my interest in this particular condition of having vitreous opacities or vitreous floaters really came from a lot of the frustration that patients have been encountering when they come to our offices over the years, and there's not a lot of great options to talk about. And in combining my interest with research and imaging, we've actually made this process of evaluating patients with vitreous opacities a lot more objective and academic. And so we'll take a leap towards this tonight so we can go over all the different ways where we can evaluate people's vitreous opacities. So getting to the anatomy, we had that first polling question. So on the right, you can see a sample of ex vivo human vitreous. And obviously the anatomy of the vitreous is such that most of it is made up of water, so a large proportion, 99% of the vitreous is water and 1% really is solid elements. Hyaluronic acid, which we've heard about before, as well as collagen, make the primary vitreous fibrils that we see inside the vitreous. As you can see here in this large diagram, there's large linear fibrils that are going from the anterior to the posterior aspect of the vitreous. And these are made up of hyaluronic acid that's bound to collagen. And what's actually intermixed between the collagen and the hyaluronic acid is water. So there's a degree of hydration of the vitreous from day one when we're born. And what happens is over time, we see that the vitreous begins to dehydrate. And that's those little loculated areas of liquid vitreous that form that we can see through sometimes when we take images or examine patients. And as a vitreous ages, it loses more and more of its solid content and has more separation of its water content from the solid content. And as a result, the collagen begins to stick to itself and form opacities. And these opacities are really what we're all going to be talking about this evening and looking at sort of how to better manage this problem, which seems pretty much inevitable as we go through our life and as we age. So as I highlighted here, there's age-related depolymerization of the hyaluronic acid. So water is lost from the protein portion. You get the formation of these liquid lacunae or liquid cavitations of vitreous, liquid vitreous. And then this collagen fibrils begin to stick to themselves and adhere and aggregate, which is now known as vitreous liquefaction or vitreous degeneration. So this whole process that happens in different people at different rates, and particularly with myopes, it's a lot more advanced and that it happens earlier. I think all of us have looked at myopic vitreous cavities and even seen much more liquid vitreous and a lot more floaters for very young patients. And that really speaks to the nature of their anatomy and, of course, this degenerative process. All right, let's look at polling question number 2. And then we'll have the answers read out for us because I want to make sure we capture all that tonight. So the question is, in my clinical practice, I use the following methods to evaluate vitreous opacities. It'd be interesting to hear what we all do in our offices, which I'm sure is a little bit different. All right, we should have all of our votes coming in there.
Okay, so the responses for clinical exam, 30%, OCT, 1%, fundus photography, 0, all of the above, 65%, other, 3%.
Wow. So it's kind of all over, you know, and I'm actually surprised that the OCT usage is as low as it is. And hopefully, I think that today's talk will definitely teach you all a little bit more about what OCT could potentially do for evaluating these patients. So that was a great question. So what have we been doing up to this point, really? You know, that's the real question. I mean, this patient has asteroid hyalosis, and it would not be really one of the patients that we'd be having a floater conversation with per se. But we see people with really bad floaters, and what were our previous management options? They're very bleak. You know, they'll drop over time. Everybody has them. Your brain will learn to ignore them. You'll learn to live with it. And, you know, for the most part, there's a good percentage of patients whereby that's true. They learn to live with it. They're not bothered by it. And I think all of us have 1 or 2 floaters we can find. But the issue is really those patients where these floaters do become an impediment to their activities of daily living and all that they find near and dear, and their vision and their quality of life is affected as a result of it. So the visual impact of vitreous opacities has been looked at, and it's been published, and it has been shown to have impaired reading vision. Patients have reduced microperimetric function. Their reading speed is slowed down. Their contrast sensitivity is reduced. Actually, I think all of us can probably appreciate that more and more being at a white background computer. You know, if you have a significant floater, you're seeing that a lot. And that's because of the contrast sensitivity. And then ultimately, you know, having an impaired quality of life. And that's all of these things are together causing significant visual impact for a select group of patients, right? We're still talking about a very reasonably small size set of patients that have this type of degree of debilitation. And so here on the right really is an old chart that I found in an article by Rosma, where they tried to, you know, quantify and qualitatively describe various types of floaters to create a sort of standardized floater chart. So you could refer to it by grade or by type. And, you know, obviously this is not practical for day-to-day use, nor maybe even necessary, but it shows that there has been an interest in this area for a long time in trying to figure out why this phenomenon occurs, what's the extent of the visual impairment, what could be done, what should be done. And so it's interesting to look back at this and see this degree of detail applied to just trying to get floaters to conform to a grade. OCT and B-scan have also been published in this area. Okay, so we've seen B-scan studies. You can see here on the right by CBAG, who's been a big leader in vitreous research, looking at vitreous opacities in a PVD in an eye using ultrasound. There's been some descriptions about OCTs shadowing and floaters inducing shadows and how that could be useful. And then here on the left, there's an image of a patient with a cyst in the vitreous, and that was imaged. But up to this point, there hasn't been a great utilization of OCT to any large extent in this area. And B-scan, of course, most of us don't use B-scan in routine clinical practice. I might, because we, as a retina specialist, you do need to use that tool, but it's not a preferred tool in any given office for looking at floaters. So how do we assess vitreous opacities? You know, so we hear our patients complain about this problem. We hear them describe the degree of impairment that they have. You know, we talked about our methods: clinical examination, B-scan, possibly ultrasound, OCT. You know, and one of the older devices that was actually described was a device which is a two luminate, whereby white light would be used to cast the shadows off of the floaters that are sitting inside the vitreous, and then those will be collected back on a follow-up screen. This through the polarizer and the analyzer shown below. And obviously, this is a very complicated way of looking at a problem that probably most of us don't pay too much attention to, but it again shows evidence that there's been thought and energy put towards trying to find objective measures to quantify and qualitate these things. So till now, I think really up until the last couple of years, in my hands, the only option for patients with bad vitreous opacities was vitrectomy. You know, and here's a patient that's having one for a macular hole, and you can see that the vitreous is highlighted there with the steroid, so you can get a sense for its diffuse nature. But you know, vitrectomy is safe, it's effective. You know, nowadays we have smaller gauge access to instruments. You can get really good reproducible results. You know, all the patients that I've done vitrectomies on for floaters over the years, you know, the handful that we do, have been very happy with it. And you know, it's really, again, for those selected patients that are that debilitated, you know, fortunately this solution still does exist. Of course, you know, we always want to counsel them about the risks like endophthalmitis, retinal tears, detachments, cataract surgery, or the need for cataract surgery thereafter. So, you know, this option has been a reasonable option, but of course does have, you know, invasive risks which need to be assessed. So let's go to polling question number 3. No, go back here. Let's go back to polling question number 3. So actually, this is a question ahead of lecture. So you know what? Maybe let's pause on this one. It's based on the studies we're about to talk about. So maybe we'll come back to that. Hang on to that thought. So what's the scientific literature show us up to this point, right? So we have some anecdotal clinical experience. We have people that have tried to make devices, tried to make grading systems. We know vitrectomy existed, but what's the science of this look like when serious attempts have been made? So YAG laser vitreolysis was introduced a number of years ago and was piloted in Europe as well as in the US in select areas. And then subsequently, a randomized clinical trial by Shah and Heyer was published in 2017, which we're going to be discussing and looking at today. And it looked at, you know, the use of YAG laser vitreolysis versus sham, or, you know, no laser, to patients with symptomatic floaters. In tandem to that, other groups were working on novel OCT applications to help them guide YAG laser to do a effective work with the YAG laser for vitreous opacities. You know, we had other groups in 2018 working on the same thing, and then, you know, more and more data going towards the role of YAG laser. What's the structure of the vitreous look like? How can we get a more objective assessment of YAG laser vitreolysis? So, you know, we're heading in the direction of making this a legitimate scientific venture where we want to prove what we're doing is effective and we can measure it. So this is the trial that was out of Boston. It's called for this purposes, I'm going to be calling it the Boston study, but it was based out of Tufts New England School of Medicine. And their objective was to evaluate the YAG laser vitreolysis versus sham laser for patients with symptomatic Weiss rings. So they looked at a very specific subset of patients with floaters, just those with PVD Weiss rings whereby the Weiss ring itself was the root problem. So it was a single center study. It was randomized controlled trial. So you either got laser or you got sham laser, or no laser. So they looked at the 6-month outcomes in terms of their subjective change in patients' visual acuity point scale, their National Eye Institute visual acuity score, their VFQ score, color photo grading was done, as well as ETDRS vision. So a number of metrics were taken sort of afterwards to really get a good handle on how to measure their vision and any outcomes of any kind. So what did they find? So they found that the patients with respect to their symptoms, 54% of them had a greater symptomatic improvement, so half of them for sure. Another half of those patients also reported a complete resolution of their symptoms. And as far as their reading speed was concerned, the reading speed revealed that there was general visual improvement in that YAG group. There was no retinal tears or retinal detachments, but there was no significant difference in visual acuity. And that part, I think, actually makes sense in this particular case, because people don't often find that their acuity is impaired. It's more their quality of vision that's affected. Reading speed, contrast, my ability to see the golf ball. Those are not really visual acuity items. They're quality of vision items. And so, similarly here, we didn't see a big difference between the sham group and the YAG group with respect to changes in visual acuity, but with respect to resolution of symptoms, with respect to the safety aspect and actually improvement and resolution, they were superior in the YAG vitreolysis group. So their conclusion actually was that the YAG vitreolysis subjectively improved Weiss ring related symptoms and objectively improved Weiss ring appearance. So they were successful in their primary goal, which was to see that for a specific subset of people with floaters, in this case the Weiss ring group, is this going to be effective? And that was shown to be the case. So how is this being done? So let's go a little bit through the science and now the device side of things. This is a modern day YAG laser, which is Q-switched YAG, of course. It's 1064 nanometers. And the key part really is that it's coaxial. Okay, so what we were not able to do with the first iteration of YAG lasers was really to be off axis when we're trying to get access to particular tissue or structure or depth within the eye. And so as you can see here on the right, if you're looking at somebody with a vitreous opacity and it's floating around in your view, you have to be able to access it and see it and treat it from all different angles. And so having that coaxial illumination has been critical in making the leap from the prior day YAG laser to the modern day YAG laser. So what about patient selection? So I'm going to show a couple of videos. We're going to get really deep into the imaging side of things. But, really when we think about these patients and who needs or should be getting any kind of procedure done, first of all, they need to have a significant degree of impairment, right? So I always question the patients 2 and 3 times over, what extent is this impairing your activities of daily living? What is it that you can't do anymore that you really love to do? So you really want to be clear on the degree of impairment. It's not just for, your Friday night floater. That doesn't really cut it. So size of the floaters, obviously, smaller is much more appropriate than having something large, denser, more diffuse. So that covers on the density side of things. And then the location, right? So, if a floater or an opacity is not within the field of view of what the laser would have or what the laser offers, it's way off in the periphery and it swings into view now and again, that's a lot more challenging. So the location makes a big difference. And of course, when it comes to number of floaters in the study, we just saw the Weiss ring was the preferred floater type. We've started with treating Weiss rings now and gotten to some more variations of it. But again, you really want to limit the number of floaters that are there to a couple, right? You're not looking to deal with an asteroid hyalosis type situation with YAG vitreolysis. And then the visualization side of things, of course, you always have to be able to visualize what it is that you're treating. So, we often have young patients come in that are referred in for floaters. I can't see anything. We image them, even on an imaging level. There's not much really there that we can detect, but they're bothered by something. So visualization is key. It doesn't mean that they're not there, but if we can't visualize it, we cannot treat it. So here's an example here on the right. This is a patient of mine that was referred, a patient of mine, but was referred into me for vitreous opacities for YAG vitreolysis assessment. And so, a couple of things about a patient like this. The size of the floaters you're looking for is a Weiss ring type person, which would be ideal. Smaller is better than larger, right? Having something that's more focal versus diffuse is obviously better. Having it mid-vitreous or is better than having it close to the retina. Having a single opacity and having it clearly visible is better than having some multiple diffusely poorly visible opacities. So as far as that goes, I mean, this guy is the floater in question, and you know, he passes. There's a couple of little floaters there. They're focal. They're not diffuse and amorphous all over the place, and they're on the smaller side. They're less than the size of the optic disc. So here's another patient that was referred for similar thing, similar vitreous opacities evaluation. And you can see this guy. This is a huge cobweb, you know, multiple string-like opacities. You know, it's a chariot in the eye. I mean, this thing's huge and really is not the ideal candidate for YAG vitreolysis. So, you know, I'm going to be disappointing some of us, right, in the audience, because like a lot of us hold that there's a holy grail here, but again, we're looking at specific patients, specific types of floaters too. I mean, you know, having seen some of these types of patients go through the YAG vitreolysis process elsewhere and come back or whatever, it's just a lot less predictable an outcome, and therefore it's not in my repertoire of types of floaters that we would go after. So the VOYAGE study. So this is a study, you know, ultimately at the end of the day, you can read all the work that people have done. You can, you know, watch cases. You can see the images that I'm showing. But as the laser surgeon in this particular case, the onus is on me to sort of explore it academically and make sure I'm happy with what it can deliver. So that was objective number one. So when we brought the laser on a couple of years ago, we started the VOYAGE study. And so the objective of the VOYAGE study was to evaluate the impact of YAG vitreolysis on the visual outcomes in OCT imaging for treatment of symptomatic vitreous opacities. So we want to find out, does this laser work for those patients and improve their visual outcomes? As well, is there a way to objectify it and look at it through OCT imaging so we could not only learn how to image these opacities, but also find objective benchmarks for when are we done? When is it enough laser? When have I succeeded all the way? So methods, you know, we'll take you through some of this stuff. It's a bit dense, but it was a cross-sectional study, 40 eyes. And actually, we're up to 60 now. So this is the first 40 results of the first 40. These patients had confirmed vitreous opacities. They had underwent Optos ultra-wide field imaging to document the opacity. They had their ETDRS visual acuity tested a week before, as well as a month afterwards. They were followed for up to 6 months, but the first month and second month, of course, they were tested for their visual imaging and their vision. They underwent swept source imaging, OCT imaging, as well as vitreous OCT imaging. And if any patients felt that there was some residual opacities, they were retreated provided they met the criteria until they were satisfied and until we were objectively not able to measure any more differences on the OCT imaging. So how do we do this? On the right here is a video of a standard YAG vitreolysis procedure. We use the laser that I showed you earlier, which is made by Alex. It's an ultra Q reflex laser, which allows for that coaxial illumination. I was the surgeon that performed it. They were dilated with traditional dilating drops, anesthetized topically, and then a contact lens that's designed for YAG was used, and the power was adjusted up to a max of 20 millijoules. And so, these were treated in multiple sessions. Some patients were done with one session. We'll see that. Some required 2 or 3 sessions. So what are the results? We had 40 eyes of 35 patients that were treated. The mean age was about 60. There was a mix of both pseudophakic and phakic patients. 35% required a single YAG laser vitreolysis procedure. 74% required a second YAG laser vitreolysis procedure, and 35% required a third and final procedure. And so we staged it like this on purpose because we really wanted to make sure that we're not putting in too much energy at any one time. So it's always better to do a little bit of under treatment and see if you need to do a little bit more, because you want to break up the energy usage that you're doing within the laser process. And so as we sort of found, we went through the process of treating these floaters to realize that really it can really be done in 2 sessions. So it's a learning curve from that perspective. But again, the good news is we were getting good data. So here's an example of a patient on the right side here too. So what did our visual acuity data tell us? Basically, we saw significant improvement in the best corrected visual acuity before and after the first treatment, but no differences after any second or third treatment. So the most amount of visual acuity gained was after the first treatment. 90% of patients reported complete resolution of their symptoms following the final treatment session. 4 patients were still bothered, and out of the 40, and they pursued a pars plana vitrectomy to get rid of residual opacities. They ultimately did great, but again, the laser also taught us which ones are more accurately the ideal candidates to go after. And again, no RDs, no tears. So, we're pretty impressed by being able to at least walk through an early pilot study like this with already 40 eyes, and we've gone well beyond that. But some of the interesting things that came out of this were, how do we objectively look at vitreous opacities? And I think, most of us that probably weren't using OCT to ever look at the vitreous before, or looking at images to the left, where you see the unaltered swept source OCT, the vitreous cavity looks totally black. And then when we increase the gain on the machine, obviously you begin to bleach the retina, and the retina begins to look white, but you start to see way more detail in the vitreous, and you see, wow, there's just so much hyperreflective material there. And a lot of this is what I was showing earlier at the beginning of the lecture, whereby, the dehydration from the collagen hyaluronic acid causes collagen fibrils to bound to one another, and you're getting these opacities right over the macula. So that was one of our gains out of this. We learned that, just increasing the gain on the OCT gave us better information. Here's another example of that. On the top image is unaltered, no gain change. And then the bottom, you can see the gain change, and you can see the whole posterior hyaloid. You can see the vitreous opacities within the vitreous there. Some of those are going to be hyalocytes, but you can just really get a different perspective of the vitreous with or without the gain. And then we looked at SLO-based imaging. So all of us, have some sort of camera in our office. If you have a Zeiss OCT, you have an SLO-based OCT. All OCTs are based on SLO. And so you can see here, we took case number 1, for example. There's a patient that came in for vitreous opacities. And just through the SLO machine, SLO image, you can see that there's this big cockroach-looking floater sitting over the macula. I mean, that sometimes doesn't get captured in a clinical exam, but the way that laser strikes these images and creates shadows in the retina gives us that information. You can look at case number 2, which is a different patient with a much larger, turtle-looking opacity. Then you have case 3, very focal, probably involuted Weiss ring in this case. And then case 4, you see a huge cobweb, right? I mean, so the technology itself has a lot of information. It's not designed for that, but really taking a look and pushing the barrier can get us there. So what do? We took another approach. We actually said, okay, could we do a real-time OCT movie, effectively, of the patient to see how their floater is really affecting their vision, right? Because on the one hand, patients can say, I have floaters, or you see it, but then you're not sure, is it really affecting? How do I tell? So here's how you tell. We actually did a dynamic OCT evaluation for this patient, and you'll see on the left of your screen is the floater, which is located in the SLO image. And then on the bottom right is an image of the same patient's floater, same time, OCT in mid-vitreous. And then you're going to look at the main right side of this screen here on top right, and you'll see the shadow that floater is casting over the retina. So I'm going to run it, and then you can see it already. The patient moves their eye, and you see the shadow going over the macula. Moves their eye again, and you see the shadow goes over the macula. That shadow. So that shadow is that floater that we see in the bottom of our screen. And, my photographer is showing me how high up in the vitreous it is. It's easily 6 to 9 millimeters into the vitreous from the retinal surface. And he's OCTing it, and he's confirming that this thing is the thing we go after. There it is right there. So, here's another example. What we can see is sometimes you don't see a focal single vitreous opacity. It's a cloud. People say, oh, I see a cloud, or I see a gel coming over, or I see it's like water or oil. They have all kind of, we all use different descriptors. And so here's an example here. This patient reports that there's like a cloud that comes over their vision. Look at the top right and the middle right screens. You're going to see that area is becoming populated with hyperreflective material. So he's got all these vitreous opacities that live on one side of the eye, and whenever he goes to primary gaze, as he's moving his eyes now again, he continuously sees this cloud of floaters go over his vision. And all those things are casting shadows, and it's obviously driving him nuts. So, that's not a great candidate per se for this for YAG vitreolysis, but again, it does show us how to rule out people that are not going to be good candidates, because again, this is diffuse, many different multiple floaters going all over the place, versus more focal, singular, and non-diffuse opacities. So we took other techniques. So we took another approach to look at this from increasing the depth of imaging. So trying to image more of the vitreous. So the standard depth that we have in one of our top machines is 3 millimeters. We try to fake it out a little further. We got 4 millimeters by stitching some images together. And then, we're starting to hit a ceiling there, but you can start to really see all the lacunae that I mentioned earlier, all the little regions of liquid vitreous, right? I mean, it really does give you a whole new perspective for the vitreous and this problem as a whole. I mean, we think of it as a single little floater, but it's sitting amidst a constellation of stuff. So it is quite complicated. And here's 6 millimeters, right? So now we're going 6, and that one floater video I showed you was probably about 9 millimeters. So, it's an exploration, but it's an enjoyable journey. But you really get a sense to see what's happening in these eyes of these people who are struggling. So the last technique we took to this was an approach called en face. So en face, for those of us that speak OCT, means looking at the OCT face on. So looking at it as if you were looking at a birthday cake, looking at the top of the birthday cake down. And so you can see here, you can see the optic nerves cavitation. You can see the posterior bursa right over the macula there. One of the lacunae, the indentation of the vessels. So this is the vitreous OCT'd on face. Okay, and actually, if you look closely, we were actually able to image individual collagen fibrils within the vitreous cavity, vitreous collagen fibrils. So there's a lot of data there. There's just, you really got to spend the time and get good capture. So here's a patient that we saw earlier who had that turtle-looking floater over his retina. Down below is the OCT, which shows virtually nothing. And then you look at the en face OCT, and that this hyperreflective turtle here is his image there. So we can actually look deeper into patients' eyes, through this approach with OCT, than ever before, and really get in there. There you go. There's that yellow box. So here's another patient of ours. We actually did dynamic OCT on them and took still images to find this floater as he moves his eye to the left. So you can see it bounces around just even within the image as he says it does, right? So again, we're trying to confirm that what we do has an endpoint. So when we go back and we image the patient the same way, we see that area would be missing because it's been successfully dealt with. So here's an example above, pre and post treatment. This patient, pre-treatment up above, you can see between the two purple lines had, kind of a collection. This was really a collection of singular vitreous opacity sort of collapsed onto itself. And then this is the patient 1 month following treatment. And you can see that vitreous cloud is absent, is gone. So, that's, and again, the vision was 20/40 before 20/25. I mean, that's, some of that's probably just, the shadowing effect from the floater / maybe even, he had a good day with me. But I'm not convinced that the acuity changes so much with vitreous YAG vitreolysis, unless it's really just smack dab over the fovea. But I think the quality of vision is something that we've definitely seen time and time again. So let's go to some real world cases. 52-year-old female here on the right with a floater for 2 years. She's multiple retina doctors, I should say opinions. 20/25, both eyes. She's having trouble with her tennis game. This thing's in her eye, it distracts her. It's been 2 years. I've tried to ignore it. They told me I would get used to it. So, one of those situations where the debilitation is real. The person was losing interest in their tennis game. So she had YAG vitreolysis. You can see it's a singular, focal linear visual opacity that's a Weiss ring, effectively this is a Weiss ring. And she had successful YAG vitreolysis. A month later, happy, gone. Complete resolution of symptoms. You know, the patients that do best are, of course, the Weiss ring patients. Those are the ones where it's the best, or if it's single focal, you know, not diffuse, visually like along the visual axis. It's when people try to do heroic things that it just doesn't work out. I mean, going after a cloud is not what we want to do. Another one here, 64-year-old male, persistent complaints of floaters for a year, 20/40 both eyes, reporting interference in computer. Yeah, so he had stopped using the computer because this thing was bothering him so much. I mean, you know, I can appreciate it. It's not the biggest thing in the world, but it's there, and he was bothered. And complete resolution of symptoms, happy, you know, did his 2 sessions, and good, you know. So it's again, being picky, being selective. So just to sort of wrap up the study that we did, the VOYAGE study, and sort of where we're going. Again, there's limitations, of course. It's a cross-sectional study. It's not a randomized controlled trial. Not that I know you'll get one in floaters, but and again, we were evolving imaging techniques for evaluation of the vitreous. There's no universally accepted grading system for opacity. Really, it's where we're doing something sort of maybe different and uncharted, but it's you know, definitely not standardized. And we're trying to get objective quantification of the vitreous opacities in some way. So I think overall what we found with this study for our group, our patients, was that YAG-VIT was less invasive. It was relatively safe. You know, it does offer another approach with OCT guidance to help get vitreous opacities. On-fos OCT of the vitreous was very helpful. We needed to titrate the treatment, so we got to 2 sessions, and the odd person needing 3, but probably all within 2. The ideal candidates, of course, single focal visible opacity within the central field of axis. They got to be debilitated. We don't want every floater under the sun getting referred tomorrow morning. And patients need to be counseled, of course, that, you know, you'll have multiple treatments potentially too, you know, again, in order to get a successful result. And, you know, we will see, as we go through it, you will have some patients that have some minor residual opacity after it's all said and done, but they're so much happier that everything else is gone that that really is no longer an issue for them. So, you know, I think it's a juggling act, but we're really getting there with respect to objectively measuring this whole process through OCT, and also managing it with the YAG-VIT when appropriate. Let's go to the last polling question. Polling question 4. Actually, we can go to polling question 3 for we kind of didn't get to do that one. Can we get 3 up there? Or you've already
Yeah,
done
we can't relaunch 3, but we can do 4.
Oh, okay. I guess, okay, let's do it. So the ideal candidate for YAG vitreolysis has the following characteristics except. I'm eager to see what everybody thinks. Oh, yeah, there we go.
Okay, so for A, small opacity, 4%, then 5%, 6%, 0%, 85%.
What was 85%?
E, diffuse in nature, 85%.
That's right. Perfect. Yeah, that's great. Good. So you guys got that. That's great. Again, you know, we're very particular. We made this thing as academic as possible. And, you know, we want to do good work. We want happy people. And I want to definitely thank my collaborators for this work. You know, my medical student, Collier Jang, my team, my photographers. You know, we're no good without our team. So especially when we're playing jazz in retina, we want to make sure we have a good team that everybody's recognized. And opening up for questions. This is actually an interesting case. This is actually one of my colleagues, and he has a big floater, and we imaged him with a 6mm window, and you can see this bird-shaped or mustache-shaped floater right over his macula. So, you know, another great example of how we can really see it all. Thank you.
Great, thank you so much. So we do have a few questions. The first question, what is the cost to the patient and to OHIP?
So OHIP does not cover floater laser YAG laser vitreolysis for patients. They do cover vitrectomy because it's not specific to what disease the patient has. There is a cost of the patient. I wouldn't discuss it necessarily over the webinar, but I think it's worthwhile if you want to connect with our office. We're happy to talk to you about it.
Thank you. Next question, what is the maximum energy per treatment session?
So it's 1500 millijoules, and that's something that I set myself. There's no recommended maximum, but my experience has been that over 1500 millijoules of power, which is a good amount of power, it's more than what you put in for a YAG capsulotomy, of course. Beyond that, you start to run into the challenges of managing the intraocular pressure because you'll get a little bit of inflammation. So, usually max for me is 1.5, so 1500. And then that's why we break it up into multiple sessions, right? So some of these floaters, they need more energy, but you can't give it in one go. You do need to break it up.
Great, thank you. Next question, do most OCTs have SLO, OFS, and dynamic OCT capabilities?
They do. They all do. So your photographer or your technician, when they capture images for you, they'll have a live view, right? There's in most machines, if not all, they have a live view whereby you can see what you're going after, and that is your moment of dynamic OCT. So, we just installed a screen capture program onto our OCT machine's computer, and we were able to capture us capturing, right, which is what we're trying to show. And that really is how that dynamic OCT sort of came to be.
Great, thank you. Another question, is this widely available? For example, is there anyone in Hamilton who could do it?
I don't know anybody in Hamilton that can do it. It's not widely available. It's available, but I don't know that many people have captured onto this because it's, again, as you can tell, it does require a very high degree of precision as well as sort of integrating these concepts together as to getting the home runs. But I do know that there are a few in the city of Toronto, but not necessarily in Hamilton. Thank
you. Next question. In one study, one patient receiving placebo YAG had RD comments?
No, not in the Boston study. Are you referring to the Boston study?
Yeah, I'm not sure.
So there was no RD in our study or the Boston study. Those are the largest studies in this topic. I didn't present any other recent studies on this, but there's no randomized control trial that's presented or published right now that has an RD in it.
Okay, thank you. If multiple floaters, is it still applicable to get rid of the central irritating floater?
It is, yeah. So so it is actually. So I guess that really speaks to the fact that, can you just target one entity of many? Yes, you can, provided it's large enough and visible. So and where it's located. So again, it's also safety and picking the right candidate. But yes, that is possible.
Okay. Another question: are there any negative outcomes after doing vitreolysis?
Absolutely, there can be. So the negative outcome is not achieving your goal, right? So there's going to be definitely a handful of patients in the early days of learning this approach where, in spite of your best effort, they're still bothered by their floaters, their original floaters. They're still not happy. So that's a negative outcome, right? I mean, no one's happy in that situation. And so that's why energy and effort, needs to be spent not only on the surgeon side, but on the educational referring provider side too, as we start to see and counsel these patients to find the right patients, right? You want the ones that they go in unhappy, they come out thrilled. So.
So what has been your experience with patient satisfaction post-YAG vitreolysis?
Vitreolysis. So I think it's been very good, and I think very good twofold. One is we've been very, very uptight about the candidates, right? Because we don't want to laser the wrong candidate. That's not going to get better because then you just got to keep explaining to them why they didn't get better. No one likes that. That's not a good conversation. So good, very good, because the candidate selection has been good. The doctors that I engage with and educate, like yourselves, they're interested in this. So they too then take an effort to figure out, okay, let's make sure that the people are going in that are going to want it, that are going to benefit from it. So that's the biggest part for us. and for me. And then the second part of it is, we've been able to actually measure the difference, right? So when a patient tells me that I'm better, can I prove to myself that they're better? So we ventured into this world of these techniques to try to capture the shadows, the physical floater, the echogenicity of it, everything we could to say, okay, before, after, how does it look? So I think that it's a two-way satisfaction for the patients in that there's a solution for those patients with these problems that works, and then satisfaction for the provider because I can actually measure and follow and quantitate the difference, versus saying it's 50% better. I would like to see what 50% looks like so I can make it 100% better next time. So that's just pushing the envelope of this technology to a way that we can get satisfaction on both sides.
Great. Now, who are the ideal candidates for treatment with vitrectomy?
So it will be anybody who's not a candidate for YAG vitreolysis, right? That whole other crowd that is diffuse, amorphous, multiple opacities, not focal, again, that's not diffuse, outside the visual axis, peripheral, that group, right? That group where it's just, no, they're not going to do well with the laser. That's the vitrectomy group. And they're thrilled because, they're so bothered by the snow dome in their vision that they're happy to get rid of it, right? So, and again, the right procedure for the right patient. That's the fundamental thing over and over.
Mm-hmm. And what are your thoughts on removing a cataract at the same time?
Reasonable if the patient has a cataract. That's one of the caveats of vitrectomy because, we don't want to be doing it on people under 40. That's not been something that I've done very often, if at all. But people that are at the cataract stage of life, it's reasonable. But again, it's a personal decision. And for some patients, again, they don't have a retinal problem. So it's a vitreous problem. So they may want certain lens selections and so forth. So I think it's a conversation. It's a two-way street there. They have to really express what they want and if they want surgery at all.
Mm-hmm. Another question, what is the waiting list time frame for vitrectomy to treat vitreous opacities?
There's no waiting list time for a particular condition. I speak to my particular waiting list at the moment. I don't have it in front of me, but it's not disease specific, meaning you're not put at the bottom of the list because you're vitreous opacities or because you're, macular pucker. I mean, emergencies are always take priority for sure.
Mm-hmm. Okay, thank you. Do you do vitrectomy for patients with significant asteroid hyalosis?
I have probably 2 or 3. I mean, there's not many. I think we all know this, right? In spite of how bad asteroid hyalosis looks when you look in some patients, surprisingly, 90% of them were not bothered. So the odd 1 or 2 times that someone really was bothered, they had it really, really, beyond 4+. And so, yeah, we've done it. I've done it for them, and they've been happy.
Great, thank you. I believe that's all the questions we have at this time. So
Right.
I'd like to thank you, Dr. Chowdhury, for your very insightful presentation.